Welcome to our video on chest tubes. Today we are going to go over how to set up a chest tube, assess a patient with a chest tube, and troubleshooting and emergency management of a chest tube. To begin, always use Mosby skills for any additional questions. Start with gathering your supplies. You will need a bottle of sterile water, additional dressing supplies, an atrium if needed, suction, and an anchor.
So these are the main chambers of the atrium chest drainage system. A is called the suction control chamber. B is where you will see titling when the patient breathes in and out. C is the water seal chamber. If there's an air leak, you'll see bubbling here. And D is the drainage chamber. Atrium drainage system. First, you're going to use this funnel to fill up the water seal chamber up to the 2 centimeter line. Next, take off this gray plug and you're going to pour water into the suction control chamber up until the 20 centimeter mark.
We're going to go through the basic assessment of a patient with a chest tube and the Pleurovac system. Your patient's Pleurovac atrium should always be placed on the floor or in a position lower than the patient's chest. I like to start at the patient assessing the dressing. So when you're looking at the dressing, you want to assess for drainage. You want to be sure that the dressing is an occlusive dressing. And you want to make sure that the chest tube is covered. Next, I'm going to palpate around the chest tube, looking for signs of crepitus or subcutaneous air. You also want to ask the patient if they're feeling any pain. As we come down the chest tube here in the patient's chest, you can see that we have the tube anchored on the patient's abdomen. It's always best to either tape or use a tube holder so that your chest tube has a lower risk of becoming dislodged. The next thing I like to look at is the connection between the Pleurovac and the chest tube. You want to be sure that it's connected, and there should always be a piece of tape spiraling around the connection here. You want to be able to visualize the connection so that if it became dislodged, you would know, but the tape on there is going to give you an extra layer of safety. As I continue down the tube, I'm looking for cracks or evidence of disruption in the tube. I'm also checking to be sure that this clamp is never in a clamped position. I'm going to continue up here to the Pleurovac itself, again making sure that this connection is stable. And then I can assess my drainage chamber here. So I'm looking for the color, the character of the drainage, and also assessing the volume of output. You should be keeping track of a running total of chest tube output in your EPIC documentation. We can come over here to the water seal chamber. If the patient has an air leak, you're going to see bubbling in this chamber. A larger air leak will have bubbling coming all the way over to the number 5. A smaller air leak will only bubble about to the 1 here. If you ask your patient to cough, it may accentuate if they have an air leak, and you'll see bubbling here. Remember, if the patient does have a pneumo, it may be normal to see some bubbling in this chamber, and as the pneumo itself is resolving, you'll see lesser and lesser bubbling. In this chamber here, you'll see titling, which is just the rising and falling of the water level. And that's a normal finding when your patient is breathing. The last thing here is the suction chamber. This should always be filled to the prescribed level of suction that the physician orders. It's typically -20. And so you can see here that our water level is filled to -20. If your patient is on suction, 20 centimeters of suction, you should also see gentle bubbling in this chamber. You don't need aggressive bubbling. The water doesn't need to be boiling, but you'll just want to see gentle bubbling here. This patient today is to water seal, which means that there is no suction attached to the end here. The valve is in the open position, which would be indicated that the valve is parallel with the tubing here. And if you were to look in it, you would see that the valve is open. You never want the valve to be in a perpendicular position like this, which would be closed off. In this situation, there's no way for air to escape from the system, thus needing it to be open. Again, if your patient was connected to suction and ordered for negative 20 centimeters of suction, this is where the suction tubing would connect to, and the valve itself could be used to adjust the amount of bubbling in that suction chamber. You may need to switch over your Pleurovac if the chambers become filled with fluid, or if you knock it over and you want to be able to get an accurate collection. The first thing you want to do is make sure you have a new Pleurovac system set up and ready to go. So you will have filled both of your chambers, your suction chamber and your water seal chamber, up to the appropriate line. The next thing you're going to do is come into the patient's room and have both of the Pleurovacs next to each other. You're going to take the blue clamp, and this is one of the only times you're going to need the clamp. You're going to go ahead and you're going to clamp off the old tubing. You're going to depress the button here and pull to get the system separated from the tubing. You're going to do the same thing on your new Pleurovac, and then you're going to reconnect here. You'll notice that you'll have this additional tubing from your new Pleurovac, and you can just toss that. You're not going to use it. And then you're going to go ahead, you're going to come over to your clamp, and you're going to make sure that you unclamp the tubing and that it's free flowing here. If your patient is ordered for their Pleurovac to be hooked up to suction, you want to ensure that the water level is at 20 centimeters. You may have to add additional water throughout your shift, and you can do that just by opening up the gray plug on the top and adding additional sterile water in. When it's time to take the patient off of suction, if the doctor has ordered water seal for the patient, you're just going to remove the suction tubing and be sure that the valve is in open position, so it'll be parallel with the tubing here.
To review emergency management of a patient with a chest tube. In the first scenario, if the Pleurovac becomes disconnected from the chest tube, you would immediately want to place the end of the chest tube into a bottle of sterile water. This would prevent air from going into the patient. In the next scenario, if the chest tube were to become dislodged from the patient, you would immediately place some Xeroform, gauze, and tape the dressing on 3 sides so that air can escape, but it cannot go back in. Reasons to call the doctor for a patient with a chest tube: if either of these scenarios happens, if you notice any crepitus when you palpate, new crepitus or worsening crepitus, it is a good idea when you notice crepitus to grab a surgical marker and mark the area so you can keep track of it. Any respiratory distress, decreased lung sound, shortness of breath, or if you notice an air leak or a worsening air leak.